Hi, good evening and welcome to this Trauma Care webinar. My name is Andrew Umrod and I'll be facilitating this evening, and I'll very shortly be handing you over to Dr. Martyn Parker talking fractured neck of femur. Just a little website disclaimer, a webinar disclaimer, that any learning that has taken place during this webinar should not solely be relied upon to inform practice or indeed allow practice outside the individual scope of qualification. Some webinar rules and facts. First of all, I can see we are very quickly growing. We've got about 650 people online already, and that number is jumping up. You will see a chat functionality, and you'll also see a questions and answer functionality. If you click in the chat, you can type in there where you are dialing in from tonight, and also maybe what you do for a living, because that will help us gauge the audience. But just some rules and facts that we can't see or hear you. This is a Zoom webinar platform, which means we can't see your cameras and we can't hear what you're saying. So if you're eating crisps or you're having your tea, don't worry, you don't need to go on mute. If you do have any questions, then please do pop them into the question and answer box and we'll filter through them and we'll be able to play them towards the end, and I'll read them out for Dr. Martyn. If you are a member of Trauma Care, then certificates of attendance will be issued to full members that attend within 24 hours. What we have known from the last two webinars is they're normally within the hour now because they're automated, and so they'll normally come out pretty quickly to you. If you're not a member of Trauma Care, I'm going to tell you some great benefits to joining, or you'll also be able to purchase a certificate separately at the end. And everybody who has registered this evening will get a copy of the recording that will be emailed to them tomorrow, normally again within 24 hours, but we do say up to 48 hours depending whether we've got several webinars to manage. And you can access the full webinar via either Trauma Care website or via our YouTube channel. So what you will need tonight is a QR code scanner, and you can simply activate your camera on your mobile phones, and where the opportunity arises, you can open your camera, point the QR code scanner at the screen and take advantage of some of the great offers that we're going to show you this evening. And some of the webinars at the very end will also be on a rotating video. So if you don't catch all the webinars or the opportunities, then don't worry. We'll be sticking around 15 minutes after Dr. Martyn spoke this evening to answer any questions, and also to display again all the QR codes that will give you a chance to register on some of the up and coming events. If you are on social media, we do love a bit of Twitter, so please do join us at TraumaCare UK and use hashtag TraumaCare 2021. Always great to see what you're doing this evening. If you've just finished work and you're cuddling your pets, or you're having a glass of wine and enjoying yourself with your tea, please do share what you're up to tonight on our TraumaCare Twitter page, and don't forget to tag us in with TraumaCare 2021. We have got some great sponsors supporting Trauma Care and allow us to bring all these events to you completely free of costs. And one of our main sponsors for tonight is Galen. And again, Galen Pharmaceutical have got some really good learning resources. So please do scan that QR code, or you can simply go across to galen-pharma.com and you can see and take advantage of some of the great learning opportunities that are available. Don't worry if you haven't got time to capture this, because I will play it back at the end, or you can always contact us and we'll signpost you in the right direction. If you're not a Trauma Care member, there are lots of great benefits, and I won't read them out to you. And again, this will show at the end of the presentation tonight, but you can have lots of great offers, including discounted tickets to the conference. You get the quarterly Trauma Care journal, which is both printed and digital online, along with lots of other tangible benefits. So again, you can either scan that QR code, or you can jump over to traumacare.org.uk and see all the great benefits to being a Trauma Care member. And again, remember, if you are a member of Trauma Care, you will get all the CPD certificates included completely free of cost for these webinars. For those people who've bought tickets for our up-and-coming conference, we've got a 5-day conference that has now got a change of date, and that will be happening from Sunday the 19th of September through to Thursday the 23rd of September. So them tickets will be coming back on sale very shortly, along with a great face-to-face event that we're hoping to hold in November. So please do follow us on social media, or you will be updated through our channels in relation to those up-and-coming events. All of these CPD webinars are a great way for you to learn, but they're also a fabulous way for you to share with your colleagues some of the learning opportunities. So I know we have lots of clinical educators who join us online. Please do take the opportunity to download this poster. I wouldn't specifically advocate you print it off, but what I certainly would do is you advocate sharing it digitally via email or via your internal intranets with your colleagues. And again, you can scan that QR code there and we'll email you the poster monthly as it gets updated, or you can jump over to traumacare.org.uk/CPD poster, and each month we'll put a new poster on there. And even if there's been a live event and the poster's still on display, if they scan the QR code, it will actually smartly take them to the copy of the recording. I have no idea how that technology works, but it just does we call it IT magic. So please do take opportunity and download that poster and share it with your colleagues and peers. All that leaves me to do now is bring you to the main event. So are you there, Dr. Martyn Parker?
Yes, I'm here. Thank you for the kind introduction.
Perfect. I'll hand over to you now. Thank you.
Okay, are we looking okay there?
Perfect. Thank you.
Thank you, and thank you for inviting me to this. And I'm very impressed with the audience numbers as well, really. So a little overdone by this. So I'm going to run you through hip fractures, really, from the immediate management and various other aspects of them. Just to say who I am, really, is I'm a somewhat unusual orthopaedic surgeon. Is basically I do hip fractures and not much else, really. So I come into work in the mornings, I assess the hip fracture patients who've been admitted overnight, do their pre-op assessment, undertake or supervise the juniors in their operative treatment, do the post-operative care on the wards, and then they have a hip fracture clinic to follow them up in. And I work at Peterborough City Hospital. It's an average district general hospital. And we have around 750 hip fractures per year now to look after. All the patients have a pro forma filled out from the time they come in, I do, and then this is updated as they go through the process and to follow up. That all goes on the computer database, so 13,000 odd patients are up on that now, and then I can use that for audit and for research, the database. In addition to that, I piggyback on randomized trials of these patients, and that goes onto the same pro forma, and I can use this to write loads of journal articles. Over the years, I've been into Cochrane evidence-based reviews, and I've done 21 Cochrane reviews related to hip fractures and a few textbooks and various other things. So hip fractures, or proximal femur fractures as they're called. The average age of these patients now is around the 81 years, around 80% are female, and invariably we've got associated comorbidities. Hip fracture patients are generally physiologically older than their age-matched counterparts. So they're more likely to have more associated comorbidities, more likely to be on multiple medication, and be frailer than their age-matched peers. And for many patients, as you get to the end of your lifespan, unfortunately, you become more doddery and unstable on your feet, and you may go through a series of falls, one of which will result in a hip fracture. So a hip fracture for some people is the sign that they're reaching the end of their lifespan, and it's part of the unfortunate dying process that people go through. And some people may wonder why we're admitting these patients and doing surgery on them, but surgery is the best way of relieving pain and getting them some degree of mobility back again for their quality of life for their last days. Not all of them are old, and we do get some younger patients with hip fractures, and they tend to fall in two distinct groups, really. So we've either got the younger one who's had a sort of significant injury, and my most recent paper we're just going to publish shortly is on cyclists, and cyclists do have a tendency to break their hip because people go out now on their bikes thinking they're in the Tour de France and go around at great speed and then fall off the thing. Some of them are strapped into their pedals now, and therefore they land onto their side and not able to get out. and then they break their hip. So it's becoming a little more common, but that's the younger patients who've got a significant trauma. Or if they've not got a significant trauma in a younger patient, there's an underlying bone weakness, and that's invariably alcoholic bone disease. So they're the two groups that we get of younger patients against the older group of female patients. How common are hip fractures? Well, we know the predicted numbers for England keep going up and up as the years go up. So the total numbers of hip fractures will continue to rise as we've got more older people out in the population there. But the incidence of hip fractures, if anything, has now leveled off. It was going up, the age-specific incidence was going up. It's now leveled off, and if anything, maybe slightly coming down now. So that's in a sense a good thing, but the total numbers still going up slowly. And if we look at the number of hip fractures around the world, that we can see for the developed countries, the numbers are just predicted to go up to a moderate amount. But if you look at the developing countries, this is where the big increase in hip fractures is going to be, because more people are going to live to older, but the age-specific incidence is also still going up in these areas. So it's the developing countries which are the big growth areas for hip fractures. So projected at about 5 million by the year 2050, but it's very rough figures depending on how this age-specific incidence works out in different countries. What's the etiology for hip fractures? It's not a single etiology, it's a multifactorial etiology, so we have to bear in mind. So you've got this sort of impaired vision, environmental hazards, people tripping over, and then impaired neuromuscular coordination as you get older. That gives you your risk of falling. Then you lose your protective reflexes as you get older, and the impacts onto the bone. And then you've got, in addition, a weakened bone structure. So you've got those three things on your left there, working towards falling over, impact on the bone, reduced bone strength, and then you get a fracture. So osteoporosis is just part of the cause for hip fractures. It's not the only cause. I don't think it's just a condition of osteoporosis. If a younger person or a normal age person is walking along, you might trip over a step or something like that. Your forward momentum will take you forwards, and you'll use your forearms as shock absorbers to absorb the impact of the fall. And normally you won't get any injury with that. If you get to your 60s and you're female, your shock absorbers aren't quite so good for absorbing that impact. And then in addition, your bones will be a bit weaker. So you might get your Colles wrist fracture in that situation. But your elderly person with a hip fracture has a slightly different mechanism. So they haven't got that forward velocity to take them forwards. They're walking slower. There's not necessarily a trip over anything. It's just a stumble of their feet. They fall over in a sideways, slightly twisting fashion and land directly on the hip. They're not able to get their arm out quick enough to absorb the impact of that fall. And so it's a direct impact laterally onto the hip, causing the fracture. So it's a different mechanism as you get older related to your falls and your loss of protective reflexes. How do you diagnose a hip fracture? Diagnosis is normally fairly easy. It's an elderly female person fallen over normally at home and unable to weight bear or walk, and the leg is shortened and externally rotated. So that's normally pretty straightforward. However, in about 5% of cases, the radiographic changes for the hip fracture might be pretty minimal. So whenever we're trying to get a fracture, we always should think we should have two views. So whenever you're looking for a fracture, always two views when you're thinking for diagnosis. Compare it with the normal side, and we're looking against the breaks within the normal contours of the bone. And you can often these days compare it against a previous film on the electronic records that we have these days. If you're not sure, then the radiographer is a very good person to discuss it with to see, and these are just examples of sort of things that might get in the way, and discuss it with the radiographer. And the one on the right here is just a grossly obese patient where you've got the big fat apron and you can't really see the hip very well. There is a fracture on that left-hand side, but what you've got to do is get somebody to lift up that fat apron out the way, and then you'll get a better view of the hip and see what's happening. So you've got to get rid of all any extraneous sort of things that are going to obscure your picture. The commonest missed hip fracture is the undisplaced intercapsular fracture. And on the left, there is a normal hip, and on the right is the abnormal hip with just a slight minimal impaction in fraction of the hip where the yellow arrow is there. And the bone has been compressed together and looks a little denser. And we've lost the normal smooth contours that you see going around the femoral neck up the top there. The bottom one's still preserved, but it's impacting up superiorly where the yellow arrow is. And that's the commonest one that's missed. And some of these patients may still be able to walk on this a little bit, albeit with assistance. So if we do suspect a hip fracture and the x-rays don't look grossly abnormal, then we'll take a third x-ray film with the film centered on the hip, rather than as those previous ones were centered on the pelvis, and taken in 10 degrees of internal rotation, as shown here. So this is a third x-ray, getting a better clarity of detail within that femoral neck, and internally rotating the leg a little so that the greater trochanter moves out laterally to see the femoral neck. And this is the same patient taken on the same time, a normal film that's generally taken in external rotation. The greater trochanter lies behind the neck and you can't really see the femoral neck. So same patient, you internally rotate the leg 10 degrees and then we can see the femoral neck appears and there's a fracture there. Even when we do this third film, we're going to get caught out in about 1% of patients when the initial x-rays are completely normal. So we've got some good quality AP lateral x-rays, maybe the third film, still completely normal, but there is a hip fracture there. This sort of patient, they won't have any deformity of the leg because obviously there's no displacement of the fracture. You may be able to get full range of movements, but it will be painful, particularly at the extremities of movement. They might still be able to walk on it, but they will need a walking aid. They won't be able to walk without holding on to somebody or some walking aid. And if you put them lying down and ask them to lift their leg up straight, then they won't be able to do it, or it will be really quite painful to do that as the muscles pull the fracture and compress on it, really. So this is a sort of patient then you should be a little worried about. So if we're in doubt, we've done our x-rays and everything looks normal, but we still think there may be a fracture, then we want to MRI scan them. And if we think to the future, MRI is fantastic. We ought to have one of these as you bring your patients in through to the A&E department. Just put them all through it, really. You cannot miss a hip fracture on an MRI scan. The T1 image is best when looking for fractures. And we can see on the right there that clear black density associated with the hematoma and the bleeding into a fracture there. So you cannot miss a hip fracture on an MRI scan. It is the gold standard. But MRI scan will tell you lots of other things. This here is an incomplete trochanteric fracture. The fracture line doesn't go quite across the trochanteric region. Only described since we had MRI scanners, didn't know about it before, can be treated conservatively just with painkillers and gentle mobilization. This here is a bone bruise. Again, we didn't know about it until we had MRI scanners. This one's actually in the tibia and the distal femur, but you can get them around the hip. Bleeding within the bone, painful, requires nothing more than analgesia and gentle mobilization, but it shows you what the diagnosis is. Pubic rami fractures, these can easily be missed on the plain x-rays. You won't miss them on an MRI scan. You've got the big hematoma around it and then the fracture at the pubic rami. An MRI will show lots of other things such as acetabular fractures, stress fractures, which is what occurs in the young sort of military recruits who are forced to do long marches and get a stress fracture around the femoral neck. Femoral head fractures can be shown up, joint effusion, soft tissue injuries, tumours, avascular necrosis. Generally speaking, if you've got an older person who's fallen over, got a painful hip, can't walk, the MRI will show you something. It's very rare for it not to show something. However, lots of us can't have immediate access to MRI scan, and then we have to use a CT. But we just have to be a bit wary about the CT because it will miss the fractures. And so the CT report may be no fracture seen, but if you really want to exclude a fracture, you've got to put them in the MRI scanner. The CT scanners are getting better now, the imaging is getting better, but it still will miss around a third to half of these invisible fractures. Move on a little bit, therefore, we've diagnosed our hip fracture. How are we going to manage it? Brief assessment of the patient for other injuries. The most common injury associated with a hip fracture is a distal radial fracture or a proximal humeral fracture. But they're the commonest sort of things, the osteoporotic type fractures. Brief assessment of the patient for associated medical condition. They're all going to have some medical conditions, but it's just whether it's severe enough to require some immediate management for the other conditions. And a brief assessment of the falls. Why have they fallen over? Is it just a simple trip, or is there something else going on? Have they had a myocardial infarction? And occasionally we see things like this with a patient in heart block here and needing a pacemaker before we can operate on them. So we get these odd sort of things with the falls. Management immediately as well is intravenous fluids, and this is sometimes neglected really for a hip fracture. And we think about, say, a young chap who's come off his motorbike and fractured his femur, we'll put a drip up because it can lead to hypovolemic shock. But it's more likely that this elderly person here may get hypovolemic shock from their hip fracture. The reason is they may have been lying on the floor for a while, they won't have been drinking, they'll be losing blood at the fracture site, they may have been given some opiates causing vomiting, and they've got more limited physiological reserve than the younger person. So this combination of events leaves them more likely to be hypovolemic. And it's known that previously that many of the patients going to theatre were hypovolemic when they measured their cardiac output. Blood loss from a hip fracture can vary quite considerably. And our hip fractures are generally put into two groups, the intracapsular and the extracapsular. And the intracapsular is shown on the left. The fracture is actually confined to the capsule of the hip joint, and you don't get a lot of blood into that. It's a fairly avascular type fracture. It doesn't bleed a lot, so they're known to have a poor circulation around that bit of bone. So that's not going to lose a lot of blood. But the one on the right, this is the extracapsular fracture, and roughly half are intercapsular, half are extracapsular, but that's the one that's going to bleed, the extracapsular. And when you look at a fracture, the more exposed and comminuted the fracture, the more cancellous bone surface that's exposed. You can imagine this is just going to ooze blood from the bone marrow and leak out into the surrounding tissue. So they get swelling of the surrounding tissues, and they can lose anywhere up to 1,000 mils of their blood volume into these sort of comminuted fractures. So it's the extracapsular ones that are going to bleed more. But until you've x-rayed, you don't know what it is. So it's best just to put a drip up and get some fluids going. These are just the basic preoperative investigations we do when the patient comes in, and it's easy to get these done in the emergency department. ECG, chest x-ray now is only really if they've got underlying chest condition that may be acutely exacerbated. Just basic bloods, hemoglobin, electrolytes, group and save. And I put in here, and some of you may wonder what's this about, why avoid doing too many tests. For example, we've got troponin T, and this is just one example. So some months or years ago now, troponin T came out as a measure of a myocardial damage. And people thought, it'd be nice to measure this in the hip fracture patients, and that's fine really. 30% of patients coming in with a hip fracture will have some rise in their troponin T. It's a measure of a patient who is struggling to cope with a physiological upset from the hip fracture. It's straining their myocardium, they're getting some damage there, and they've got a raised troponin T. It's a marker of a frailer patient. That's fine. But then there's some people who said, well, they've got a raised troponin T. Let's just be a little more careful with these patients. Let's put them on one side. Let's do some more investigations, maybe initiate some sort of treatment prior to surgery. And there were a few case series, and this is just one shown here. So these patients were put to one side, had a medical referral, more investigations. Their mortality for those with a raised troponin T was significantly increased to those with the normal troponin T. There were other people, myself included, who said, hold on a minute, this just doesn't seem quite right here. So we put all our samples in the fridge for 3 months and left them there and then measured them afterwards. So we didn't know they got a raised troponin T and then looked at it. No increase in the early mortality for those with a raised troponin T. There was a slight increase in the late mortality, reflecting the frailer group of patients. So people were getting it wrong. They were thinking we should be more careful with their raised troponin T, where they were doing it completely wrong and increasing their mortality by delaying the surgery in those who were struggling myocardially. And there's lots of other previous examples of such things in the literature. What sort of analgesia do we want to be giving to these patients? Well, intravenous paracetamol, as we all know, is fantastic. Oral paracetamol, of course, can be done. Oral morph, codeine and paracetamol is fine. Intravenous morphine is okay, but we're aware now, we just need to be cautious about this in the elderly because it can have quite a delayed response and not work for about 15 to 30 minutes. And you keep thinking it's not working, we'll give a bit more, and then suddenly it works and the patient has a respiratory rest. So always a little more careful of the very frail elderly with the poor circulation and intravenous morphine. Intramuscular morphine is still okay, and we tend to avoid the non-steroidals because of the risk of causing gastrointestinal upset and renal damage. Nerve blocks we like, really. Nerve blocks seem good. There's a nice Cochrane review on it. They're effective. They do reduce the amount of pain the patients get, and they reduce the amount of the need for the opiates to get. There's even some people now have started putting an epidural in the A&E department, and it may be the way forward, just to reduce this physiological upset caused by the pain to these patients. There's a little bit of debate about how you put your nerve block in, whether you should use a landmark technique and which landmarks you use, or whether you use ultrasound, or whether you use a nerve stimulator. It doesn't seem to matter much. All of those techniques are effective. What does matter more is to use a large volume of low strength, so something like 40 mils of 0.25% Marcaine. So it's the big volume, and then that spreads around the tissues and spreads around the nerves. And you're hoping you get more than just the femoral nerve, is you'll try and get the sciatic and the obturator nerve as well, the so-called triple nerve block. And you're more likely to get that if you've got a big volume of anaesthetic going in there. Traction, in the olden days, we used to put people on traction with a hip fracture, but then people questioned it with this sort of evidence-based medicine concept, and they had some 9 randomized trials, all showed it was a complete waste of time putting people with a hip fracture on traction. It didn't relieve their pain at all. It did no benefit whatsoever. So traction is now no longer used for hip fractures. We do still use it for the femoral shaft and the subtrochanteric fractures. But again, I think you perhaps really need to sort of begin to question it a little bit. Maybe we'd be better just putting these patients in a position of comfort and getting them to theatre as soon as possible, rather than doing the traction. So that's the best way of sorting it out, is get these patients into theatre. Got to think about other things, pressure areas in these frail elderly patients, and how to avoid that. So it's avoiding delays, using soft mattresses, turning the patient on the side if they've been on one position for more than a certain amount of time, because they're a bit more prone to these pressure areas. And the pressure sores will start from the time of injury, obviously, onwards. Tranexamic acid, very much the flavour of the month for everybody these days, isn't it? We know tranexamic acid is good for our elective surgery. It's probably good for our hip fracture surgery, although we're still lacking some of the evidence. We need some more trials. So a single dose at the time of surgery does seem to reduce blood loss and transfusion requirements. But maybe for the trochanteric fractures, that's those that bleed more too late at surgery, we need to be giving it before surgery in the A&E department. It's not proven as yet, but that's the way to look forward really, and future research is tranexamic acid for the trochanteric fractures in the A&E department. And that's more likely to be a benefit, stopping them bleeding at that time, because they start bleeding from the time they get the injury. Most A&E departments now have a fast-track policy of getting them to the ward, and as I said, basic assessment for these injuries and associated medical conditions, set up the drip, take the routine bloods, timely setting up the drip, give some analgesia, and try and fast-track to the ward within 2 hours. And this is sort of the sort of thing that many places have. We have a sort of a little tick box thing, check have we done the ECG, bloods and all that, ring the ward, ring the doctors, get them sent up there as soon as possible, a fast track policy. I'm going to operate on these patients. Why are we going to operate on them? Well, our number one reason for operating on these patients is to control pain. And that's our number one thing, really. It's the best way of controlling pain after a hip fracture. But it's got extra bonuses as well. We can get the patient back on their feet again. It allows them to regain their mobility. It reduces morbidity or pressure sores, pneumonias, thromboembolic complications. So they'll all be reduced by getting the patient out of bed and back on their feet. And it will reduce the mortality. So everything is favouring surgery, really. We do conservative treatment, not operate on a small number of patients. It's around 2% of patients in my practice that we won't operate. We get 1 or 2 who present late, a week or 2 after the injury, and it's one of these impacted intercapsular fractures. It's not displaced. The patient says it's getting better now, the pain's getting less. You can let that fracture just heal on itself. So you get 1 or 2 of those. You might get, they're pretty rare in the UK, these stress fractures from the young people and military recruits and the like. They be treated conservatively. You can argue for a patient who's immobile when they get their hip fracture, what's the point in operating on them, because you're not going to get them mobile again. But generally speaking, even for the immobile, that we'll still operate to control the pain. But not only that, is that when we say they're immobile, they're often using their limb to transfer out bed to chair with 1 person, as shown there. And you don't operate on them, they can no longer transfer out bed to chair with 1 person. They need a hoist or 2 people to get them out. So they're in pain and even more immobile than they were before. So we'll operate even on those that aren't walking. Terminally ill, if they're expected to die within a week, then it's possibly just best just to not to operate on them. But it's a difficult decision, and sometimes you can get caught out. And if I'm not sure, then I think we should go and operate on them, even though they might die within the next week or 2. It's just because we're not going to do any harm, we're going to make them more comfortable for their last days. What are the surgical issues for these patients? So we divide our hip fractures into intercapsular, extracapsular, roughly half and half, and the intercapsulars can be undisplaced or displaced as shown there, and about 20% are undisplaced and the remainder displaced. And your trochanterics can be divided into your trochanterics and your subtrochanterics as shown there. Your intercapsular fractures, the majority we will treat by putting in a hemiarthroplasty, the half hip replacement in there for that. We will use a total hip replacement, that's the full replacement that's used for the arthritic hips, for the fitter patients with a displaced fracture, and that's about 5 to 10% of patients. And the reason we're doing that is the fitter patients are more active. They might wear out that articulation between the metal head and their articular cartilage if they do a lot more walking, so that we'll put in the cup to go with the arthroplasty. And then for the younger patients, and those with undisplaced fractures, then we'll tend to treat those by internal fixation with some sort of implant going in there. And for the younger patients, we're worried that if you put in an arthroplasty, they're going to wear it out as they get older. So if the person's going to live more than around 30 odd years or so, then that's a high risk they're going to wear out that hip replacement. We'll try and fix that first. So anyone younger than 50 or 60, we're going to be looking towards internally fixing it. And the older ones, if they're fitting well, can have a total hip replacement. Majority will get the hemiarthroplasty. And your extracapsular fractures, essentially, we can either put a plate and some screws on it, or we put a nail in it. And both of those work perfectly well, and they're both used extensively around the world. But the tendency is a little more these days going towards the nail, as it seems a quicker, less traumatic operation. And it's also the nail that we'll be using for the subtrochanteric fractures. So that's the way trends are going, but the plate fixation is still fine. When do we want to operate on these? Basically, if you fall over and break your hip, you want it to be operated on as soon as possible, because that will make it more comfortable. You can get out of bed and get on the go and begin to get back home again. So we all want to operate on these as soon as we possibly can. And we know, we're looking at all the studies that have been on it, early surgery will reduce the death rate from the hip fractures, it will reduce mortality, it will reduce the morbidity, the pressure sores, pneumonias, thromboembolic complications, and it will reduce hospital stay. So everything is favouring early surgery. And there's been a change over these years. Previously, it used to be thought that the very elderly, the very frail, we would put them to one side and be a little more careful and a bit more slower getting to surgery. And that was found out to be wrong, really, because these are the ones that are less able to cope with this delay to surgery. They're more likely to get the physiological upset, the complications, and subsequently die. Where it's the younger ones, the fitter ones, that can actually wait for their surgery. So generally speaking, the sicker, the frailer patients, the more urgent it is to get them into surgery. And this will be the best care they'll get during their hospital stay for these frail patients, is actually when they're in the operating theatre, when they're all monitored and sorted out as best as able. When we get to surgery these days, surgery, it shouldn't take more than an hour as a general rule for these operations. It's more minimally invasive than it used to be from the days from the large incisions. We're moving on towards minimally invasive surgery. Blood loss should be less than 500 mils, and it's got to be technically correct for these. So there's been a considerable change in our technique over the years. We do get complications from surgery, but a lot of these are actually can be related to the surgical competence, really. So arthroplasties can dislocate, wounds can all get infected deeply, and our nails and plates can cut out and fall apart. But the risk of this occurring should be roughly less than 2%, approximately, for these sort of things. So the complications do occur, but they should be fairly rare. After surgery, then this should be what we'd be doing: mobilization the day after surgery, immediate mobilization, full weight bearing for all, no restrictions these days on hip movements. We check the bloods on the first day to see if they need a transfusion, and no check x-rays need to be done immediately. You can do them later on to see how they're doing, but not to delay getting them out of bed. And this has made a big difference, getting these patients straight back on their feet. We've got quite a bit of good evidence on randomized trials, and we've had some big trials looking at what our transfusion thresholds should be for hip fractures. And the result is essentially it's 8 grams per deciliter is our transfusion threshold. You can put it up to 9 for those who've got significant cardiovascular disease. And that's sort of fairly standard now. Oral iron is of no value whatsoever for these patients unless you come in with an iron deficiency anemia. And just to move on, really, that's how we're managing the patients. What happens to these patients after all when we've done them? So back in 1979, Professor Grimley Evans was from up in Newcastle. He was a geriatrician, and he looked at a series of patients coming through his hospital in Newcastle. And basically this was to shame everyone in how badly these patients were treated back at this time. Average hospital stay for his series of patients, 75 days, with over a third of them dying in hospital. And this was done very much to shame people and say, this isn't good enough for our management of hip fractures. And he was quite right, and it's changed enormously over the years. We know over the years that our patients, the average age of a hip fracture patient coming to hospital has got older, and it goes up progressively over the years. So it used to be around the 70s, and now we're up at, as I say, 80, 81, 82 for the average age. So our patients are getting older, but our mortality has gone down slightly, 1 year mortality, despite the fact that we're doing older and frailer patients. And that reflects our better management of these patients. So the immediate outcome after these patients come into hospital is we will get 88% of them will go back to where they came from. There will be about 5% who can't go back home, who will need to move from their own home into a residential or nursing care. But quite a number of these were struggling at home before. They were the at-risk ones who weren't really coping, and then they need to move to residence, a different residence, and the hospital mortality rate is somewhere between 5 to 7%. Average hospital stays around 3 weeks at the moment, but if you always get some that linger longer because of particular circumstances or complications. So your mean hospital stay is 3 weeks, but your median stay, half the patients will go home by 2 weeks. For these. And then if we look at these patients at 1 year, those who came in from their own home, 68% or so will still be back there in their own home managing. 11% will have to move into a more dependent accommodation, residential or nursing home, and 21% will have died at 1 year. And if you look at those who come from the institutional care, from the nursing, the residential homes, then this is where the big mortality occurs. This is people who are very much at the end of their lifespan, and by 1 year, around a half of them will have died. 1 or 2 would have had to move from residential to nursing care. So, summarise up really, how do we treat the hip fracture in the present stages? Is don't overcomplicate it, don't do too many things that are going to make it worse, and just simplify it, simple tests. Get them into operating theatre as soon as possible. So the quicker we can get them into operating, the better for everybody. Then we need, once we get there, we want quick, effective surgery. We don't want prolonged surgery and operations these days. So we want more skilled, effective surgery, immediate unrestricted mobilization, full weight bearing for all these patients, and then get them back home before they've quite realized what's going on with it. These are key references we use in hip fractures. The sign guidance is the Scottish guidance on hip fractures. It's a little dated now, but it gives you the start to finish management of hip fractures. It's very clear and easy to read. The NICE guidance is more current, but it only covers certain aspects of the hip fracture pathway, and it is a lot more wordy and difficult to read. And we've got anaesthetic guidance from the Royal College of Anaesthetists related to anaesthesia, what sort of anaesthesia, which ones to delay, which ones to get on and operate. And these are absolutely fantastic and up to date and very clear and marvellous. Thank you very much, and I'm open to any questions.
Dr. Martyn Parker, thank you very much indeed. What a great presentation. And we have got lots of questions. I've managed to filter some down because you answered some fabulous questions towards the end, but let's hopefully get through some of these questions. Let me just share my screen back up on the board, and then we'll go for questions. Okay, so we've got our first question, which is from Viv, and Viv's asking, do you think there's a place need for pre-hospital nerve blocks for these patients, and what are the risks of doing these pre-hospitally?
Yes, they can be done, particularly if you're in the Outer Hebrides. I mean, that's the sort of ideal thing, isn't it, really? So your nerve block, if you're using Marcaine, it might take a little while to work, but it's going to last some 6, 8, 12 hours. So if you've got a long transfer in, yes, that's the sort of thing. If you've only got a short transfer in, it's probably not worth it. So I think it depends a lot on that, really, as to how long and what sort of roads you're going to be transferring them in. It's a pretty safe technique. So once you've been taught how to do it, nerve blocks are really safe, basically. Okay, there's some vessels, but you can be taught the technique where you give the injection into the lateral space, so that's more laterally into the soft tissues, use the large volume, and then let it spread more medially towards the nerve. In that way, you're going nowhere near the vessels, so completely safe from that. So yes, they have a place. They do definitely reduce the pain and discomfort they get. They reduce your opiate needs. They probably don't make a lot more different than that. So but it is basically, so I think you've got to think how long is your transfer going to be and how tricky it is for getting these patients there.
Fabulous. We've got a question from Edmund. Edmund's asking, is there a risk when giving fluids pre-hospitally of knocking clots away?
Knocking clots away? I'm not intravenous fluids. No, I'm not quite with you there. No. So intravenous fluids pre-op, again, it depends a little bit where you're transferring in. If you're transferring in from the Outer Hebrides, yes, drip pre-hospital, fine. If you're just coming down the road to the hospital, it's not much point, really. I'm not, in terms of clots, and you shouldn't be dislodging any clots or anything. No, I'm not quite sort of following you there, really. You won't get your thromboembolic complications, your pulmonary embolisms and that until normally 7 to 10 days post-injury. You get those. So no, that's okay. But pre-hospital drip, again, it's a bit like your nerve blocks. If you can do it and you've got a long transfer, fine.
Excellent, thank you. We've got a question from Louise. Louise asks, is there a risk of pelvic fractures as well as neck of femur in elderly patients from standing fall, other than pubic rami fractures? Would the consideration of a pelvic bind benefit the patient pre-hospital, or would it cause more discomfort, aggravation to the neck of femur fracture?
So when you an elderly fall, you break a bone, it's either a hip bone or a pelvis bone, but you can't, you can, but it's very, very rare to do both together. So the fall impact is absorbed by one bone or the other, and it's extremely rare to get a hip fracture in the same time as a pelvic fracture. So no, you either get one or another. And a pelvic binder, no, even for a pubic rami fracture, I don't think it's probably going to make much difference to you, really. So no, no, your pelvic binder is only really for your opened big pelvic trauma type case, really.
Excellent, thank you, Dr. Martyn. Rachel is asking, has there been any studies linking early frailty assessment in prediction of risks of hip fractures?
I mean, there's lots and lots of studies these days like that because everyone's got their database. So basically, elderly, frailty, multiple comorbidities, multiple medications, falls, smoking, alcohol, all these things are associated with subsequent hip fracture. So there's loads of studies on that, and frailty is certainly one up there that's associated with hip fracture, yes. So there's lots of studies, and they'll move on and they'll look at things like frailty associated with hip fracture and an increased risk of mortality. But a lot of it is, okay, so it's there, we know about it, what can you do about it? And it's one of these things, a lot of it you can't do much about. We all get older, we all get frailer, we all get more doddery on our feet, we'll all start to fall over, and we'll begin to break our hips. So there's less you can do about it, but we know it's there and it happens.
Excellent, thank you. Great question. We have got a question from Mark, which is a question mark that I've always wondered. How many times can a hip replacement be done to the same hip?
Well, there's no set number really. You don't want it done that many times really. So ideally, when you put in a hip replacement, you want it to last for life, basically. That's what you're always looking for, and to try and match your hip replacement, that it will last your life. Sometimes they go wrong, it has to be replaced, and sometimes that goes wrong and has to be replaced. There is no set time, but the more it's done, the harder it gets and the higher the failure rate, essentially. Keeps going up and up, your failure rate. So the more it gets done, the less likely you are to get a good outcome. So you want as few revisions as possible, but it sometimes happens.
Excellent, thank you. Tim has asked a question for our pre-hospital practitioners here tonight. If we come across a neck or femur fracture on the hill away from definitive care, hopefully we get an helicopter for transport. Is there a best way to splint this for transport, position and comfort?
No, so it is whatever is comfort really. So just leave the leg, if it's short and externally rotated, leave it in that, support it with the pillows, towels, blankets, whatever you've got to keep it just supported in that position of comfort. So that's normally external rotation, keep the patient supine, and then scoop them or whatever you can onto your stretchers and so on. So no, putting your traction splint on is probably not necessary for these, for the hip fractures. Maybe for your femoral shaft, but not really for your hip fractures. It doesn't, because it's quite painful to apply onto a hip fracture, putting on the Thomas type splint of thing. So no, it's whatever's comfortable, just keeping it best padded up with blankets, whatever, and transferring as gently as you can.
Excellent, thank you. I can't believe we've had over 1,200 people on this webinar tonight. That is absolutely amazing, thank you. A question from David. Is there any correlation between calcium, for example, milk from young age, to cultures lacking calcium uptake in bone density?
So generally speaking, the higher the calcium and dieting when you are younger, the better it is for getting you a good, strong bone structure for later life, really. And there's a lot of talk these days about whether some foods should be supplemented with calcium so that our population going through these days has a higher calcium intake. So that would be a good thing if it were, but then they've got all the ethical things of putting stuffed fortifications into food. So the more calcium you get in the younger age, the better. Yes, it will take you through with a slightly stronger bone structure. Whether calcium supplementation as you in the older age is of any benefit is still a very controversial thing. It may have marginal benefit, but you begin, if you're doing calcium supplements with the calcium tablets, then you may get side effects of your abdominal upsets, constipation, renal stones. So it's risks and benefits really. So actual calcium supplement tablets probably not necessarily a benefit unless you're definitely short on your diet. Try and get plenty in your diet, particularly from the young age.
Excellent, thank you. We've got a good question from Sam that most people on tonight's webinar will be asking who work in a pre-hospital field. Are there any tips for managing these patients in the pre-hospital setting, and what would be the most ideal, almost if we were to have a pocket Dr. Martyn Parker with us, what would be the most ideal bundle to bring them into accident emergency with, Martyn?
There's nothing specific really. It is just assessing the patient, just checking there's nothing major else going on. They've not had a big heart attack that's caused them to fall over or stroke, something like that, which is unusual. It's normally just a trip over at home. It is just reassuring them that that's what they're having. They come in hospital, they'll fix it up in the hospital, get them back home again, and just trying to reassure them. We always think it's a good thing when someone comes into hip fracture to start fairly early on, because some people, particularly elderly, will think a hip fracture means either death or total disability. It's the end of their life. And so you've got to start off and you can start as early as you like, reassuring that's not going to be the case. They're going to go in the hospital, they're going to have an operation, it's going to get fixed up, and they'll get back home again in 1, 2, maybe 3 weeks' time. So it's a little just reassuring them that this is what it's going to be. It's not death. And it used to be said that in the olden days, yes, you fell over, you broke your hip, that was it, it's a terminal event. But obviously it's not the case now, really. So a certain amount can be reassuring, and doing that sort of thing, that it's not going to be complete disaster for them, and then just sorting out, bringing their tablets in with them that they've got, and checking they're all okay to come in. Analgesia, if necessary, put your nerve block in if it's going to be a long while.
Excellent. Thank you, Dr. Martyn. We've got, as fast as I'm reading these questions out, the faster they will. We're now up to 66 questions outstanding, so we're not going to get through them all, unfortunately, but I've got time for a couple more. Question from Alexander. Are females more prone to hip fractures than males? And if so, why? Yes, so it is largely, unfortunately, fractures in the elderly is largely a condition of females. So 70 to 80% of the elderly fractures are female. It is due to the osteoporosis, which is more common in the females, and that's due to the menopause and the loss of the estrogens. So once you lose your estrogens at the menopause, then you begin to lose bones, your amount of bone stock that you have at a much greater level than the men do. And that's the big difference. So up to the menopause, you're running on pretty similar. Once you hit the menopause, the men just carry on losing bones slowly, as you do with old age, but the women lose it much faster because they've lost their estrogen. And this is where potentially estrogen replacement therapy can be, is thought to be a benefit. So it is largely, or not a condition of the elderly females, unfortunately, osteoporosis. Excellent. Thank you, Dr. Martyn. Question from Rob. Is there any correlation between the severity of the pain experienced and the severity and type of fracture? Yes, there is. So the trochanteric ones are always more painful. So this is one with all the fracture and the fragments and the bone surfaces that are broken. So the more the periosteum that's damaged, the more painful will a fracture be. It's the periosteum that's got all the nerve fibers in. So that's the acutely painful thing. And when you move a patient with a fracture, it's the periosteum moving against each other that causes all the pain. So the more comminution the fracture, the more pain you'll get. So the trochanteric fractures tend to be more painful, and these are the ones which have a little more deformity, a bit more shortening, external rotation. Whereas the intercapsular ones, it's not going to deform as much, the fracture's confined to within it, and they're not quite so painful, these aren't. So it will depend a little bit on where your fracture is, yes, as to which ones can cause most pain, yeah. Excellent. Thank you, Dr. Martyn. We've got a technical question from Dominic saying, Dr. Parker, thank you. We want to ask a technical question. What are your views on the trend of dual fixation of neck of femur fractures in the younger patients? Have seen some small cases or a series of anterior medial plating via anterior approach combined with lateral fixation. Yes, so for the younger patients, we're going to fix up that fracture by whatever means we can, because we don't want to put in a hip replacement, because that will wear out before they get too old, and then they need the revision and maybe the further revision. So for the younger ones, we're going to try and fix it up. For the extracapsular fractures in the younger patients, then it's still basically the plates or nails, that's fine. But for the intercapsular ones, then there's a lot of debate going on whether you put screws and how you put your screws in and where. So, and there's even some people putting in extra plates, and these medial plates are going in. It's pretty tricky putting a plate on the medial side of the femoral neck, getting to it. So it's a tricky operation. You've got to expose quite a bit, and the question is exposing all that, does it cause more damage than good? So this is something that's been looked at too. It's a research area at the moment, looking at different implants that can hold the fracture better for these younger patients. The thing is, they're quite rare, these fractures, so it's difficult to work on and get any sort of rapid progress in this, because you're only dealing with a small number of patients, and it's difficult just saying that you've done a small number on a series of 10, 20, 30 patients. Is that any better than someone else who's done a different series with a slightly different implant? But that's the way things are going at the moment. It's looking at, can we use different implants to hold them together in a bit of stronger fashion? Medial plating is one, but it's very much a sort of research area at the moment. Excellent. Thank you. Great question. And we've got a last question from Moaz. Moaz is asking, do surgeons have a preference for general anaesthesia versus spinal anaesthesia?
No, so for a hip fracture, you can either have a general or spinal anaesthesia. It really doesn't make a lot of difference. There's 1 or 2 patients who you want to do a spinal. Those who are really chesty, have got the chronic chest disease on home oxygen, that sort of stuff. These are the ones that you tend to think they'll be better off with a spinal. But for the majority of them, general or spinal anaesthesia is fine. It doesn't seem to make a lot of difference. There's been lots of research over the years looking at the two and randomizing between the two. But essentially, it doesn't make a big difference. And it doesn't bother the surgeon either as to which one they have, as long as they get one or the other.
Excellent. Dr. Martyn Parker, thank you so much for tonight. We have got questions still coming in. We'll be here till 10:30. But I will try and, for all those people who's asked questions that we've not answered, I will try and get some of the questions answered offline for you and try and get back to you. But Dr. Martyn, thank you so much for giving your time tonight to support our trauma care community.
No, it's a pleasure. And I'm very impressed how many people are interested. Yeah.
Yeah. Wow. Thank you very much. Yeah, indeed. Okay, so just a few more things to talk about. I'm just going to explain to you some of the other great features that are coming up. And we have got the Trauma Care Manual, which is now available. So if you haven't already got a copy of the Trauma Care Manual, you can buy that online now. You can simply scan the QR code, or you can go over to traumacare.org.uk/shop, and you'll be able to purchase a copy of the Trauma Care Manual. We have got a brilliant webinar coming up on the 21st of April, which is Commanding the UK Ambulance Services Through the COVID Pandemic, presented by Professor Anthony Marsh. Again, you can scan that QR code, or indeed, you can jump over to traumacare.org.uk webinars. We've got Professor Ken Dunn on the 5th of May 2021 at 8 p.m. talking impact of early management on the burns care pathway. And again, you can scan that QR code, or you can jump over onto the website. And we've got the role of the interventional radiologist in trauma, presented by Robert Jones on the 14th of June 2021 at 8 p.m. So please do jump over there and register for that webinar. That will be very popular. We are growing a really, really good following of physiotherapists and occupational therapists. So welcome on board. And please, as I said earlier, do share some of our posters with some of your colleagues. And please also do tell us what you want us to cover for the future. We're very fortunate that Trauma Care has almost got a 12-month program of webinars lined up now, so please do let us know what topics and subjects you'd like us to cover. And again, we've got a new sponsor come on board, which is Watergel Technologies, so please do jump over to watergel.com, or you can scan that QR code, where again there's some excellent resources for you to learn and develop your knowledge and skills. All that leaves me to do is say again, thank you very much, Dr. Martyn Parker.
Thank you very much. No, pleasure.
And thank you for all those people who took time out tonight to join us on this Trauma Care webinar. I will stay on board for the next 10-15 minutes, and I will rotate the video across. But for those people who have not caught up on the webinars, please stick around if you have any questions. I'll be happy to answer them on chat. And for those people who are working, please stay safe and do enjoy the rest of your shift. For those who are not working and at home, please do put your feet up, relax, enjoy the rest of your evening, and thanks for supporting Trauma Care. Good night, take care, and stay safe. Thank you.